Good afternoon, friends. Today we will discuss about anesthesia, various types of anesthesia that are given in cataract surgery, various techniques of anesthesia. You must be aware of the types of anesthesia like general anesthesia, local anesthesia, topical anesthesia. So, which type of anesthesia we use in cataract surgery? We use all types of anesthesia, friends, but the most common anesthesia that is used is peribulbar block. And nowadays, topical anesthesia is also coming up. So, uh, what do we mean by general anesthesia? In general anesthesia, what do we do is we give injectable or inhalational drugs to anesthetize the patient, and then we do the surgery. Is it required in ophthalmic surgery? Usually it is not required. It is required only in small children or in mentally disabled patients, or if there is a bad injury to the eye where the risk of perforation with the local anesthesia is great. In that situations only we use general anesthesia. So the next type of anesthesia is topical anesthesia. So how do we do it, friends? We just put drops like a 0.5% proparacaine drops in the eye, and we do the surgery. That's it. That is called as topical anesthesia. But this anesthesia usually cannot be employed in all types of cataract surgery. In phacoemulsification, where when the touch to the ocular surface is minimal and the surgery is fast, in that situations only we can use the topical anesthesia. Again, we require the patient to be very cooperative, and patient should understand our commands or our instructions. Then only this topical anesthesia is possible. Nowadays, in refractive surgeries, we almost exclusively use topical anesthesia. So the most common type of anesthesia that we use is peribulbar block. So what do we do in peribulbar block? In peribulbar block, what do we do is we inject anesthetic agent around the eye. Peri means around the eye, so that it reaches the nerves that carry sensation from the eye and reaches the muscles, and it produces anesthesia. So what do we want during cataract surgery? We want ocular anesthesia, means patient should not be aware of what is going on. Patient should not have any pain. That is called as anesthesia. Then second is we require ocular akinesia, means the patient should not be able to move the eyes during surgery. And the third thing that we require is paralysis of facial nerve, because the patient should not be able to close the eye. The patient's eyes need to be open, and if there is a squeezing movement, that's not good for the surgery at all, because it causes positive pressure and it may cause iris prolapse or vitreous thirst. So that we require facial palsy also. So all these objectives are um, easily achieved by peribulbar block, and the peribulbar block has got a great margin of safety also. So that's how we do it. So what do we require to give peribulbar block? So which drugs which we use, and what is the rationale behind that? So we use 2% lignocaine, a combination of 2% lignocaine and 0.5% bupivacaine. So why the need of combination? Because lignocaine gives faster onset of anesthesia, whereas bupivacaine sustains the anesthesia. It prolongs the effect. So that's why these both drugs act synergistically. So we use a combination of 2% lignocaine and 0.5% bupivacaine. We also mix hyaluronidase into this combination because it allows the spread of the drug easily through the tissues, so that the onset of anesthesia is faster. So we what do? We take a mixture of 2% xylocaine or lignocaine plus 0.5% sensoricaine and hyaluronidase injection. So that is the mixture that we use. So how do we do it? I am trying to show you a video which which demonstrates the peribulbar anesthesia. So just let me try, friends. So you just observe this video, and I will try to explain also the procedure. So you notice that first this local area is cleaned with betadine betadine drops before giving the anesthesia. Now the surgeon is, what is he doing? He's palpating the lower orbital margin. There is a bony margin which is palpating. So there is a notch that is situated at the junction of medial 2/3 and lateral 1/3 of the lower orbital rim. So that is the point of injection for the lower side. Basically, we give usually two injections, upper and lower. So now he's using a needle. This is 23 gauge needle, but we commonly use 24 gauge needle. And please note that the bevel of the needle is towards the globe so that it doesn't cause perforation. So slowly we are not going in directly to the globe. What we are going is, we are going towards the orbital margin. We are hitting the bone and then we move upwards parallel to the globe. So once the hub is totally, we inject the needle till the hub, then we aspirate little bit to check whether we have perforated any blood vessel or not. If blood comes out, then we'll not inject, we'll withdraw and we'll do a separate injection. Then slowly we inject around 5 ml. Okay? Yes, we are injecting 5 ml of the drug, right? So after this injection, what we do is, we ask the patient to close the eyes, and then usually we try to spread that drug with the help of gauze piece. See, we can give gentle orbital massage also at this stage. Just ask the patient to close the eyes and we want to spread it. Okay. Just let me see whether, okay. Now here they have not demonstrated the technique of the upper injection also. So have you understood? What the surgeon has done here is, he has injected 5 ml of xylocam mixture, anesthetic mixture here. So after injection, what we do is, you ask the patient to close the eyes, and then you just put a gauze piece on the patient's eye, and try to gently press, to put two hands on the glove uh, be- above the watch piece, and just press with the upper hand and keep the lower hand like this, and this will help in spreading of the anesthetic drug. Once that is achieved, then again you palpate the superior orbital rim, friends. So this superior orbital margin you palpate. So notch is situated here, exactly opposite or diagonally opposite to the lower notch. So this is a supraorbital notch at the junction of medial 1/3 and lateral 2/3. So what the surgeon will do is, he will inject 5 ml drug here also. And while we are injecting, we can see that the lower lid droops down slightly, and there is slight proptosis that indicates that the block has reached the peribulbar space. So once we achieved that, then what do? We do again the massage. We do the massage for 30 seconds, release for 5 seconds, and again do the massage for 30 seconds and release for 5 seconds. This is because if you do massage continuously, then we might cause occlusion of the central retinal artery or vein, and patient may become blind because of that. So we do the massage, right? Have you understood this? So once we do the massage, then this massage is for spreading of the anesthetic agent, number one. Second thing is, because we are causing increase in volume of the orbit, there may be rise in intraocular pressure, or there may be positive thirst. So we want to reduce this vitreous thirst by giving massage. And if there is chemosis because of the block, then it also helps to reduce the chemosis. Sometimes the leads become tight with the block. So this is how we block. And the once after we are sure that there is adequate ocular anesthesia and akinesia, we ask the patient to move the eyes. And if you find that the movement of the eyes, ideally there should not be any movement of the eye, but small slight movement may be acceptable, and then we proceed with the surgery. Most important, you should also see whether the patient is able to close the eyes, because if the patient is able to close the eyes, then that means that our anesthesia is we require facial anesthesia, because that is not desirable. Then we can additionally infiltrate some more drug into the peribulbar space. So I hope you have understood how do we give peribulbar block. We have to check and we have to adjust. Sometimes the block doesn't come, then we have to supplement the block. And if the facial block doesn't come, then we can, you please see the cursor, yes. Then we can give various facial blocks, means blocks which block the facial nerve. So there are various techniques like Van Lint method or O'Brien method and all. I'm not going to details about that, but simple method is Van Lint method, in which we inject some drug here at the lateral canthus superiorly into the eyelid and inferiorly into the eyelid. That is sufficient for achieving facial block. So with as no procedure is without risks and complications. So what are the complications of perivulvar block? Sometimes the blood vessel may rupture into the retroorbital space, causing retroorbital hemorrhage, and that is not a good complication. That's a risky complication. The patient, how do we recognize the complication? Usually there is proptosis, means आंख बाहर आ जाती है, आगे आ जाती है. Then there is lid edema, then there is redness of the globe, congestion. So these are the signs of retroorbital hemorrhage, and the pressure of the eye is also raised. So in such situation, what we do is we do ocular massage. We do ocular massage for 5 minutes and see. And if we find that the pressure is lower down, then we may proceed with the surgery. But if the pressure doesn't get lower down, then sometimes we have to postpone the surgery. And if the pressure is too high, then we have to do something called as lateral canthotomy, where we cut this lateral canthus. We make with the help of scissors, we just cut the lateral canthus so that the pressure is released. So that is also has to be done sometimes. And we can also give hyperosmotic agents like mannitol to reduce the intraocular pressure. So that is one complication. The second complication is perforation of the globe. I have already told you that we have to go away from the globe. We have to go parallel to the orbital floor and orbital roof, means orbital orbit when we are giving blocks. But sometimes, especially in patients whose eyes are big, like in myopes, there is a risk of perforation. So if there is perforation, then there will be sudden hypotony, means the intraocular pressure will be reduced, and the patient also has pain, and the glow, fundal glow, will be might get obscured. So if we recognize the signs of perforation, then we have to manage it accordingly. So that is the second complication of perivulvar block. And systemically, if the xylocaine reaches the blood vessels, then it can cause cardiac arrhythmias also. And as with any drug, there may be xylocaine, there may be hypersensitivity or allergic or anaphylactic reaction to the xylocaine. So to avoid that, before giving the block, we just give a small amount here in the hand or in the arm to check for the xylocaine sensitivity test. That is like penicillin and all. So that also is a complication of this block. So that is the most common type of block that we perform in during cataract surgery. Sometimes we give retrobulbar block also. Retrobulbar means peri means around, retro means behind the globe. So we go literally behind the globe. So we have to use a larger needle, a thicker needle, and we go beyond the orbital septum, and then we give a little amount of this. We require less amount in retrobulbar block, but the procedure is risky because we are going behind the globe. So sometimes we may perforate the globe. So the risk of perforation and retrobulbar hemorrhage is more with the retrobulbar block. So I hope, friend, that you have understood what do we mean by peribulbar block. Peri means behind, peri means around, retro means behind. Then what is topical anesthesia? What is facial anesthesia? And what are the indications of these different types of anesthesia during cataract surgery? So that's all for this small lecture. In the next class, we'll discuss about the techniques of cataract surgery, means steps of cataract surgery. Thank you so much, friends.